The Developing Well Child, Part 3. Therapeutic value is seen as the child is allowed to express themselves through emotions, words, and actions. Moral value is developed as the child has learned what is acceptable and unacceptable behavior when playing with other children or in a home or school setting. School-age children look to their friends for security as they develop independence. Adolescents look to their friends for a sense of belonging. Separation anxiety is a major form of stress from middle infancy through the preschool years, especially from 6 to 30 months. It usually begins around 6 months old and is more pronounced in toddlers. Due to the limited number of coping mechanisms in infants and children, it is a stressful situation. By 4 to 8 months, the infant will notice the departure of a parent after it occurs. And during the second half of the first year, they begin to protest their crib and they may object when mom leaves the room. The infant may not notice if they are preoccupied with other activities, but they do tend to protest when they do realize that mom has left. By 11 to 12 months, they begin to anticipate the departure by watching their mother's behaviors and then begin to protest the anticipated departure. Protest can last from hours to days, and it can result in total physical exhaustion. Separation from the primary caregiver can cause the following responses. In late infancy, we see cries, screams, searching for the parent with their eyes, clinging to the parent, or avoiding and rejecting stranger contact. With toddlerhood, in addition to what I just mentioned, we may also see verbally attacking strangers, physically attacking strangers, attempting to escape to find the parent. Attempting to physically force the parent to stay is another behavior. Despair can last for a variable length of time. The child's physical condition can deteriorate from refusal to eat, drink, or move. Behaviors that might be observed would be inactivity, withdrawal from others, depressed, sad mood. The child has a lack of interest in their environment. They're uncommunicative. They regress to earlier behaviors such as bedwetting, thumb-sucking, or pacifier and bottle use. With detachment and denial, detachment usually occurs after prolonged separation from the parent. It is rarely seen in the hospitalized child. These behaviors represent a superficial adjustment to loss, and it shows increased interest in surroundings. They interact with strangers or family caregivers. They form new but superficial relationships. They can appear happy but resigned. In other words, they're not content. The goal is to prevent separation of the child and the parent. We need to encourage the parents to interact with the child and be present when they're able to be. Most hospitals will not put limits on when the parents can be with their child. We assign a primary nurse, and this assists in maintaining consistency with the caregivers and decreases the number of strangers who go into the child's room. Educate the parents that if they inform the child that they are leaving and they will return later, that the child may only cry for a few minutes and not the entire time. As for timekeeping strategies, it's very important that you understand younger children have a limited concept of time. So instead of saying 5 o'clock or 2 o'clock, we tend to say such as when the sun comes up instead of in the morning, or after Scooby-Doo is over. So this helps them deal with the concept of time. Provide home-like atmospheres to help make the child feel like they're at home with their favorite toys or activities that tend to decrease stress. Encourage socialization with the family and visitors when they're present, and promote the child's independence by allowing them to perform any activities they can do independently or to make any decisions when it's appropriate. Food provides heat and energy It builds and repairs tissues, and it regulates body processes. Nurses need to identify children at risk for nutritional issues and then assist the family to modify their eating habits or diet to ensure adequate nutrition for appropriate growth and development. So you need to look at the USDA guidelines to determine appropriate intake. Do not significantly restrict fat and cholesterol intake because it's used in the development of the central nervous system. 1 tablespoon per year of age is the guide to serving size. Discourage sweet drinks or snacks just prior to a meal. And be aware of potential drug and food interactions. As far as fiber needs of the young child, it's 0.5 grams per kilogram. If we provide too much fiber to a young child, it can inhibit their appropriate nutrient intake by causing them to feel full much faster. Nutritional needs will change with illness. The child may exhibit poor appetite and fluid intake, and each situation should be assessed individually for appropriate needs. Some of the foods that are more likely to be involved with allergies include eggs, cow's milk, wheat, strawberries, nuts, peanuts, and corn. So let's look at each individual age. With infants, their digestive system is immature and it functions minimally the first 3 months. They have minimal saliva to help aid in digestion. They do require more calories, protein, minerals, vitamins, and fluids than other children. Infants require 108 kilocalories per kilogram per day for formula-fed infants, and breastfed infants may need to be fed as frequently as 10 to 12 times a day. Exclusively breastfed infants, or those infants that ingest less than 500 mLs per day, should receive vitamin D 2,000 international units for the first 2 months. Begin iron-fortified cereal daily at 4 to 6 months, and discontinue those at 18 months. Well, the iron-fortified cereal, not necessarily, but the vitamin D. Begin fruits and vegetables at 6 to 8 months. Meat, fish, and poultry at 8 to 10 months. Prepare meats by boiling them, baking them, steaming, or poaching. Eggs and cheese can be given at 12 months, with the yolk being hard-boiled and mashed, soft-cooked, or poached. Don't microwave bottles to warm them up. It causes unequal heating of the formula. Signs of underfeeding include crying, restlessness, and a failure to gain weight, where overfeeding signs are regurgitation, mild diarrhea, and rapid weight gain. We should never give whole cow's milk to a child before they're 1 year old, and no low-fat cow's milk before they're 2 years old. So with toddlers, at 12 to 18 months, they require 102 kilocalories per kilogram and 1.2 grams per kilogram for protein. There is a slight increase in the need for vitamins and minerals in this age group. Physiologic anorexia is where toddlers have decreased nutritional need and a decreased appetite at about 18 months of age. Grazing is a really good way to ensure proper nutrition for this age group. The child also becomes fussy and picky at this time as to the foods they tend to eat. Iron-fortified cereals and iron-rich foods are recommended. Make sure again that you give child-sized portions. They need 500 milligrams of calcium, 200 international units of vitamin D daily, and a cup of fruit daily. We only restrict trans fatty acids and unsaturated fats, not the other fat, because again, 30% of their calories should come from fats. Toddlers are able to begin feeding themselves by the end of the 2nd year, but parents should be present at meals. With preschoolers, from 18 months to 5 years, their nutritional needs are 90 kilocalories per kilogram a day, or about 1,800 calories a day. They need proteins of 13 to 19 grams a day. Fluid requirements are 100 mLs per kilo per day, but it does depend on their activity level. Total fat intake should be no more than 10% of their total caloric intake per day. The recommended calcium intake is 500 milligrams for a 3-year-old, and that does increase to 800 milligrams a day at age 4. You should avoid having the child eat everything on their plate because it can lead to overeating and development of poor eating habits later in life. These kids like finger foods. Dawdling behavior at mealtime is very normal, and they are vulnerable to protein and calorie deficiencies. With school-age children, middle childhood average caloric needs are 1,200 to 2,400 calories a day, with vitamin and mineral supplements daily. They should avoid empty calorie foods and fast food because childhood obesity is a risk for this age group. A child's like and dislikes from early childhood will follow them to later childhood. An intake of protein, calcium, vitamin A, and ascorbic acid is usually low in the school-aged child. And food attitudes are very unpredictable in this age. With adolescents, they're experiencing rapid and extensive increases in weight and height, as well as muscle mass and sexual maturity, and all of this increases their nutritional requirements. It is important to involve adolescents in their food choices. Adolescent caloric needs differ for boys and girls. Girls are an average of 1,600 to 2,400 calories a day, with boys being 2,000 to 3,200 calories a day. Vitamins and mineral supplements, again, should be taken daily. Many adolescents eat or don't eat according to social pressures, and obesity can be an issue. Dietary deficiencies are more likely as a result of an increase in fast food and or junk food, as they're able to make more of their own choices, skipping meals, or increased snacking, and eating fads. Different diets, vegetarianism, and sports can also cause deficiencies. Many adolescents suffer from eating disorders of bulimia and anorexia nervosa, or both, with the peer pressure to maintain a certain weight or body shape. With bulimia, it's more common in the older adolescent girl and young woman. It's defined as repeated episodes of binge eating, then compensatory behaviors, such as laxatives and diuretics, self-induced vomiting, fasting, or excessive exercise. It's also called binge purge. Anorexia nervosa is a refusal to maintain a minimally normal body weight, and you see severe weight loss in the absence of obvious physical causes. A lot of anorexic nervosa clients can develop bulimia. And obesity. 1/3 of the United States children are overweight, with 30 to 40% being considered obese. Obese children often become obese adults. And obesity in children is usually, like adults, related to inactivity and diet. This is the food guide pyramid for young children up to 6 years of age. And for vegetarians. Remember that pain is whatever the person says it is. Patients that are in pain secrete a higher level of cortisol. They have compromised immune systems. They experience more infections, and they show delayed wound healing. That's why it's so important to make sure that pain is taken care of. But children can refrain from reporting pain because of fear of injections, for example. Infants are assessed for pain according to their behavior, And they usually have the following responses at a young infancy age. There can be some generalized rigidity or thrashing with possibly local reflex withdrawal of the stimulated area, loud crying, facial expression that includes lowered brows and tightly closed eyes, with the mouth being open and squarish. It actually forms almost a square. No association is demonstrated between an approaching stimulus and subsequent pain. With the older infant, they're likely to have these responses: localized body response with a deliberate withdrawal of the stimulated area, loud crying, facial expressions of pain or anger, and physical resistance, especially pushing the stimulus away after it's applied. The toddler and preschooler can exhibit the following responses to pain: loud crying, screaming, but realize that their crying may be due to anxiety rather than pain. Verbal expressions such as ow, ouch, it hurts. Thrashing of the arms and legs, pushing away the stimuli before it's applied, lack of cooperation and the need for restraints, a request to terminate the procedure, stop, stop, clinging to the parent, the nurse, or someone else, requesting emotional support such as hugs, restlessness or irritability with continuing pain, and anticipatory pain can cause these behaviors as well. With a school-aged child, we may see all the behaviors of a young child, especially during a painful procedure, but less during the anticipatory period. Stalling behaviors such as, wait a minute, or I'm not ready. Muscular rigidity such as clenched fists, white knuckles, gritted teeth, contracted limbs, body stiffness, closed eyes, a wrinkled forehead. School-aged children often view pain as a deserved punishment for something that they did. Adolescents have less vocal protest and less motor activity, but they have more verbal expressions such as, it hurts, or you're hurting me, and increased muscle tension and body control. Non-pharmacological pain management can be drawing, distraction, sweeties, which is that high concentrated sugar solution, imagery, relaxation, cognitive thinking strategies, back rub, and massage. Pharmacological pain management considerations, I'm not going to list the different medications, but there's different things we need to consider when we do administer pain medication to children. The drug elimination can be influenced by immature body systems. Adequate pain relief allows a child to focus on their surroundings and activity, where inadequate pain relief will cause the child to focus on the pain. A more effective pain control can be achieved if routine around-the-clock medications are given. And if you're planning to start an IV or administer an injection, sometimes you can use Imla cream to numb the site. Let's look at different behavioral pain assessments. We look at distress behaviors, which is the vocalization, facial expression, body movement. These are all ways to assess pain. The FLAC pain assessment tool assesses the facial expression, leg movement, activity, cry, and consolability. Scores will range from 0 to 10. The CHIOPS, we look at cry, they get 1 to 3 points. Facial 0 to 2, verbal 0 to 2, torso 1 to 2, touch 1 to 2, and legs 1 to 2. The scoring is devised as a 0 being behavior that is the opposite of pain, 1 is behavior that is not indicative of pain but is not the opposite of pain. Behavior for number 2 is indicating mild or moderate pain. 3 is severe pain, and you can have a total of 4 to 13. PICI, PICIC is crying with or without tears, screaming or groaning, a distressed facial expression, tense body, and irritability to touch. TPPPS is for children ages 1 to 5. The vocal pain expression, cry, scream, groan, moan, grunt, is measured, as is the facial pain expression, the open mouth, lips pulled back at the corners, squinting, closed eyes, furrowed forehead, and a brow bulge, and body expression. Are they restless? PPPRS. The parents will track the number of behaviors that their child has to rate the child's pain. And the child may not admit pain to anyone but the parents, so the parents may be the best ones to provide this assessment. The APPT is for children and adolescents. We look at the location, intensity, and quality. It's a one-page double-sided assessment with a descriptor list and word graphic rating scale on one side and a graphic of the front and back side of the outline of the body. The descriptor scores will range from 0 to 56. Each component is scored separately. Excuse me. And PPQ assesses the patient and parental perceptions of pain. There's 8 questions that include pain history, pain language, the colors children associate with pain, emotions they experience, their worst pain experience, the ways they cope with pain, the positive aspect of the pain, and the location of their current pain. 3 components will include the visual analog scales, color-coded rating scales, and verbal descriptors. The child, parent, and the physician will all complete this questionnaire separately. With the FACES pain scale, this is recommended to be used for children that are ages 3 or older. The Oucher scale is a 0 to 100 scale, with 0 being no hurt, 1 to 29 being a little hurt, 30 to 69 meaning middle hurt, 70 to 99 being a big hurt, and 100 is the biggest hurt the child could ever have. The word graphic rating scale will use descriptive words to describe pain from no pain, little pain, medium pain, large pain, to worst pain possible. And child stressors. Some children will deal with stress by regressing, which is the loss of an achieved level of functioning, such as wetting their pants regularly after being toilet trained. Ill children suffer stressors due to separation anxiety, a loss of control, bodily injury, and pain. With toddlers and preschoolers, separation anxiety is the greatest. Preschoolers can handle short periods of separation, but not extended periods, and children express in various manners. The loss of control. The toddler will strive for autonomy. Altering their routine will give them a sense of a loss of control. And preschoolers, physical restrictions with medical equipment and being in the hospital setting or due to the illness will give the child the sense of loss of control. With bodily injury with this age groups, it can be perceived or actual. Pain is a major stressor for children, even when it causes minimal or short-term pain. With a school-age child, separation anxiety, they are in need of parental guidance, so separation from parents does pose great stress and anxiety. With loss of control, they are striving for independence and productivity of their life activities. They also have boredom from the restrictions the illness places on the child. And with bodily injury, they do need procedures to be explained well and in terms that the child will understand. Adolescents suffer from separation anxiety. They have varied emotions. Hormonal at this age and they want to do what is right, but they've got a lot of peer pressure. They don't need their parents as much. With loss of control, these kids are struggling for independence, self assertion, and liberation. And bodily injury. They also need procedures explained very well in terms that they will understand.